So what is photogrammetry? And why is it not always possible to use? And why is it frustrating to use when you've spent a lot of money on something which costs tens of thousands, but to give you accuracy, but it's difficult in situations? Well, photogrammetry really assumes that you can see everything in the frame and look at everything in one go all the time. But in real life, patients aren't always easygoing. It isn't always an easy scenario that we're using photogrammetry in. The tongue can get in the way, the lips can get in front of scan bodies, and that can mean that really without line of sight, we have to move things around, and it presumes stability that is easier in mind than it is in practice. So in terms of what we want from a system to capture all on X, we need something that's flexible, something that can work in different clinical scenarios, and that's where ScanLadder comes into play. Because realistically, if we want to be able to provide an all-X solution, we need something that will help be able to capture that in all manner of different scenarios. So whether we can see everything in one go and we centralize it, or whether we have to position things a little bit differently. So let's look at two examples of this. So when we look at the ScanLadder in the mouth, or whether we compare it to photogrammetry, we can actually see sometimes with photogrammetry in the mouth, if we have things in the way, whether it be the lip or the tongue, it can make your life difficult. And the same thing is true with all-on-X scan bodies. ScanLadder has a different way of thinking than pretty much anything else on the market. How do I know this? I'm a clinician, I invented it. So the reality is that ScanLadder was born out of frustration in using different systems, but also it's understandable to use as a clinician, because the main thing about the way that it's designed with a lot of different features to be able to make your life easier. So let's recap how that positions in the mouth. If we think about what the ScanLadder is, it has a lot of different aspects of it that really make up the full patent, the overall protected IP, but reality is in the mouth using it, we have not just the common cylinder that makes your libraries easier to use. We don't have to use software, we don't have to upload anything, we don't have to convert anything. It's there for the lab. But in use, there are features, and the reason why we have the surface the way that it's designed, a random surface with different voids, the thing that nobody's copied because of it, is because that allows you as a clinician to use it in different scenarios, exactly like we were talking about. So the individual features, the individual shapes, the way that each scan body is a different size allows you to really spec what you're doing to fit the patient in the scenario that you're working in. So we can see that very easily in two different ways here. So in this one, we have an upper arch where we have the different scan bodies centralized that you can see are positioned so that we can see all of those in a central location. So we bring the scan, we scan that, minimizing the number of frames to increase the accuracy exponentially. It means that we can only scan that central bit and we get the position of all of those scan bodies. But the problem is we can't always do that. So systems where they've taken some of the best ideas that we like to think that, oh, we will use this centrally, you can't use it in some situations. And I was at the AEDC a couple of weeks ago where we were looking at this with a few users of ScanLadder who came over to literally tell us, I'm so glad we invested in ScanLadder because I wouldn't have been able to use this if it wasn't for the ability to maintain accuracy in a different way of doing things, which is arch-based. So why is this appropriate in some situations? Well, if you think about the tongue can get in the way, the tongue can be of different strengths, pushing on scan bodies, the patient could be sedated, the lips could be in the way, and the tongue could be sitting really far forward. So it'd be impossible to fit everything centralized. The anatomy of the arch might be such that if the anatomy is really ovate or really opened out, that the position of the implants might mean that those scan bodies are never going to centrally locate, then any system where it relies on that instantly cannot use them. So it means that we have the option that if we cannot centrally locate, we can position as a secondary option around the arch. And they're not small scan bodies either, where some systems might be only focused on arch-based, they can't centrally locate, but they might be small scan bodies and still leave really large gaps in between the scan bodies. And if those gaps are large, then it defeats the whole purpose of the scan accuracy intended to be increased with an all-on-X scan, because it's edentulous scans which are inaccurate. So these scan bodies you can see positioned here, these are entirely covering that soft tissue. Now you might be thinking, in that situation, how do we match the data? Well, we'll come to that. But with this, we've covered all of that soft tissue, the scan bodies run all the way around that arch. So as the scanner is there, those features, the geometry of the scan bodies, allow each and every frame to match together perfectly, so that overall we end up achieving a really accurate result that can still provide when we can't use central location scan bodies. Now, if we've covered all the soft tissue there, then we wouldn't be able to match the soft tissue if there was no soft tissue to be able to match in cases like immediate placements, big open flaps, bloody fields. But because this is raised up above that level, it doesn't matter if the soft tissue is our position, because we have the tissue sync scan bodies. So whereas we would need to really here in other systems maybe upload to platforms, scan software, whatever, transfer, we don't have to do any of that. We simply scan with the scan ladders in that arch form. Say in example, we couldn't use the central location, and then scan with the tissue sync later at any time. After surgery, when the surgery is finished, we soft tissue, close up, suture, then we scan with the tissue sync, or even 6 months down the line when everything's healed, scan again with these in place. And because the multi-units are in the same position, the tops of those tissue sinks, the cylinders, are also in the same position. So we can match those two data sets perfectly. So that enables you to really customize your approach for all-on-X to fit every different scenario that you want to use. So really, the whole thing about scan ladder, not only is it about accuracy, it's about geometry, not optics.